All right, so today I've got a little bit of a different video. We're into module 9, and for this module, instead of having set topics for us to talk about, we get to pick our own. And so when I was looking at the different topics, one of the things that really stood out to me was this short article called Lessons from a Home Birth Practice by Dr. John Stevenson. It comes from midwiferytoday.com from autumn 2003. Pretty sure it's online and you can find it if you want to look at it and read the whole thing. It's only about 3 pages, but it's packed with tons of good stuff in there. And I've used it multiple times in consultations with couples about them planning their birth. And yeah, it's just super, super useful. So he was a general physician for 20 years. And then he says quite accidentally, he became involved in home births when a patient requested he attend her home birth. And within a year, he had to abandon his general practice because he had so many requests for him to attend home births. So I'm just going to share some of the things that really stood out to me from this article. So right off the bat, he starts out talking about that when labor begins, the mother is in charge, as she should be, which I think is a great note to start off on. And he said that he observed that intense bonding occurs within the first half an hour after birth, not in the first week, as obstetricians tend to say. Stevenson also said that he values this as equally as important as safety, as it affects the baby's long-term welfare and the mother's psychological health. This bonding, he says, is automatic. You don't need to help it, but you do need to protect the mother from embarrassment, humiliation, and separation from the baby. So in light of this, Dr. Stevenson learned to resuscitate a shocked baby without cutting the cord and removing the baby from the mother, which I thought was super interesting. In the first 3 years of his practice, he learned that there are amazing safety mechanisms built into the mother and the baby. And the first he talks about is the oxygen reserves of the baby. He said that the oxygen carrying capacity is about 40% more than ours due to denser hemoglobin concentration. And if you want to learn more about this concept of fetal hemoglobin and how it differs from ours, Khan Academy online has a really good video on this if you want to learn a little bit more technically about it. But essentially what this means is that the reserve of a baby is more than that of a child outside the womb or of an adult. The second thing he notes is that most babies are still pink at birth despite their oxygen supply being reduced once the baby reaches the mid-pelvis. So I have my really cool pelvic model here. And so if you don't know where the mid-pelvis is, this is the pelvic inlet. And then the middle here is called the mid-pelvis, and then the bottom here is called the pelvic outlet. So once the baby's head is about in this position, kind of in the mid-pelvis, that is the point where the oxygen flow starts to be reduced. And I also talked about this in my video called Why Babies Breathe, I think, that I did a while back. And I talked about how a baby, as they're closer to being born, has a reduced oxygen and increased carbon dioxide, which helps to stimulate that breathing mechanism once they're born. And it's a physiologic process. And so this lack of oxygen will show on a scale of kind of pink to blue. So it can evolve from pink tone to the skin, which most babies are born pink. Then it kind of changes to purple, and then it can also even become blue. And a baby that is born with any of these colors usually still has some oxygen reserves and will most often breathe without help. So when the oxygen reserves run dangerously low, that's what we call shock. So the skin circulation closes down, there's no muscle movement, there's a deathly pale kind of gray complexion, and the heart rate goes down to about 80 beats per minute from the usual like 120, 130 of a baby. And so Stevenson would quickly make these observations within about 15 seconds or less and begin to get oxygen into the baby's lungs using his own breath rather than pure oxygen, which is interesting. And he talked more about why that was the case. But but he would inflate the baby's lungs once and with the air from the dead space in his trachea rather than like a full oxygen, a full breath from the lungs. And most often this would immediately raise the heart rate to about 100 beats per minute. Sometimes it would fall back down and he would give another breath, and then it would come back up. Occasionally he would do a third, but he found he never needed to do more than 3 breaths in his practice. And once a baby breathes on its own, he said it needs no more help, but patience and confidence are key because it can take up to 10 to 15 minutes for muscle tone to return and for a baby to cry. And this is a pretty long period of time if you're just having birthed your baby and you're the parent sitting there waiting for your baby to start to move and not be so floppy, and for them to start crying, as we're so used to hearing that like dramatic cry as soon as a baby's born. And so yeah, he was saying patience and confidence are necessary on the part of the caregiver. He also said that shock is rare if you don't use drugs, which in a home birth practice, just based on the context and what's available to you, you've probably used a lot less drugs than you might find in a hospital setting. He said also that he never would use APGAR scores. He preferred to describe a baby's condition by color, movement, and heart rate, which I think is very practical, very easy to see and to determine, and maybe a little bit quicker than trying to figure out an APGAR score. He also said that another safety mechanism built into the baby is the baby's ability to withstand shock, which is far superior to ours. So if I turned blue, like from lack of oxygen, within minutes, there would be brain damage beginning to set in. Whereas if a baby's heart rate is down to 70 or 80 beats per minute, you can expect a full recovery if you act promptly. And with a heart rate of even 30 or 40 beats per minute, which is really low, you might be in trouble, but still a baby might be able to be resuscitated. And he had a few other really interesting points about a nuchal cord, about birth of the placenta, and a few other things. And so I definitely would recommend you look up this article if you found any of those points interesting. But yeah, I think it's super interesting because it's pretty rare in our society, and especially in my context in Canada. I don't think there's any doctors that I've ever heard of who attend home births or have a home birth practice. And so it's really interesting just to hear from someone in a different part of the world in a different time. This was maybe, I don't know, this was written 20 years ago, so maybe he's probably was practicing the 20 years before that. So yeah, interesting to glean bits of information from all different people and their experiences. And yeah, I hope you found it interesting, and thank you for watching.